All right, good morning, everyone. I'm Sean Alcantara. I'm one of the vascular fellows here at Sinai. We have an interesting case to present. It's a 78-year-old man. He has an asymptomatic 6.5 centimeter AAA. He has had significant past medical history, including diabetes, hypertension, and CKD. His baseline creatinine was above 2, and had a history of stroke. However, he was functional and independent. So on physical exam, he had a non-palpable right femoral pulse. The left side was intact, and the aneurysm was pulsatile. So just to go through the CT scan, we have just above the celiac, SMA, and then right at the renals, we see a significant aneurysmal degeneration with thrombus. And on the right side, we see loss of contrast on the external iliac, and also a very large left inguinal hernia. So there's a lot of significant planning involved in terms of trying to manage this case. We certainly have problems on the right side with access, and then in terms of preserving flow to the right leg, we wouldn't be able to do any sort of fem-fem crossover or anything like that. So the options at this point is to do a conduit on the right side to the common iliac, and then we'd be able to deliver a device. The other option would be to do a sort of like an aorta uni and come from above with parallel grafts. And then we'd probably have to do like an ax-fem on that right side to preserve flow to the right leg. For this gentleman, we decided to do a conduit on the right side. We used 10 millimeter HemoShield graft. It has to be large enough that we can safely pass our device up. And in terms of the aneurysm repair, since it's essentially a juxtarenal aneurysm, we decided to use a custom Z-Fen graft. These are just, this is the wrong, I'm sorry, sorry, that's not the right presentation. It's not HIPAA compliant, but we were able to, so we took him to the operating room. We started with the conduit, and at this point we decided that we had to cover the internal iliac in order to obtain adequate seal. So we started with an Amplatzer plug on the right hypogastric to cover that area. And at this point, we have the proximal fenestrated device in place. And once we are satisfied with the position, then we proceed with cannulating each of the two renals and the SMA. Once we have we generally put these sheaths we advance all the sheaths and wires and balloons, balloon mounted stents in place. And then we open up the top cap and deploy the proximal portion of the fenestrated graft. Once we achieve that, then we can deploy our precannulated stent grafts into both the left renal and then the right renal. The right renal did have a little dissection in it, so we placed an additional bare metal stent to ameliorate that. Following this, we have our distal port bifurcated portion, which was deployed in standard fashion, just making sure we're below the renal arteries. And at this point, we have our completion angiogram, which shows good filling of our SMA2 renals and flow down both legs. And that's it.